Okay, Assalamu alaikum everyone. I hope everyone can hear me and see my screen. Before I introduce myself and what we're going to talk about right now, let me just remind you that when you think of a nerve, right? So a single nerve, let's say a radial nerve, musculocutaneous nerve, any nerve in your body, it's made up of multiple nerve fibers, okay, which are also known as neurons. Okay, which are also known as neurons. So a single bundle, a bundle of neurons is called a nerve. Okay, so just remember that for the rest of this review. Hopefully that will, clear out some of the misconceptions that you might have later on. Okay, so assalamu alaikum everyone again. My name is Safwan. I'm a medical intern. And today I'm going to review with you the brachial plexus and its injuries. Now, I know that you guys have your exam on Thursday, so I'm going to tailor my review more towards techniques to solve questions. Towards the end, we are going to have, a solving question session kind of thing. Of course, at any time, if you have any question, any query, feel free to put in the chat, raise your hand and ask. Everything's fine by me. Okay, again, so this is more of a review. So I might go through some of the basics really quickly, although there are some basics that I feel like I should explain to you because I did not find them in the lecture that was provided to me. So I'll do that as well. Okay, but my main focus is going to be more exam oriented. Okay, because that's, you're preparing for the exam, so that's how the lecture should be. Okay, I'm going to talk about a very important concept of the formation of a spinal nerve. We'll talk about the nerve plexus, and then we're going to talk about the brachial plexus, and then we're going to talk about the injuries to the brachial plexus towards the end. Okay. Usually this is about hour 45 minutes, this lecture, okay? Depending on the number of questions we have from you guys. All right, you're welcome. So when we talk about formation of the spinal nerve, we have to go back and talk about the central nervous system, which consists of the brain, which is in your head, and the spinal cord, which is in your spine, right? So when we talk about the spinal nerve, we have to focus on the spine, and this is what I have highlighted here. Now I'm going to take a section of the spinal cord from here, and then we're going to look at it in a cross section and see how a spinal nerve forms. Okay, this should be easy since you guys have already taken the lecture. So orienting ourselves, this is the spinal cord right here. Okay, this is the spinal cord right here. This is anterior portion of the spinal cord or ventral portion of the spinal cord. This is posterior or dorsal. Okay, so anterior is the same thing as ventral. Posterior is the same thing as dorsal. Usually ventral, dorsal, these terminologies we use when we talk about the nervous system. Okay, so we have anterior and we have posterior. Now, any part of the central nervous system is made up of the gray matter and the white matter. Okay, what is gray matter? Can anyone tell me?
The cell bodies of the neurons.
Excellent. And what is white matter?
The axons, the myelinated axons.
Excellent, very good. So cell bodies of the neurons are present in the gray matter, and the myelinated axons are in the white matter of the central nervous system in general, be it the brain, the spinal cord, the brainstem, whatever. But here we're focusing on the spinal cord. So if you look at this here, this green structure, that is the gray matter right here. Okay, and the rest is the white matter. So gray matter is in the center, and the white matter is on the outside. The anterior portion or the ventral portion of the gray matter in the spinal cord, which is this area right here, just remember that it's responsible for the motor function, okay? And the dorsal or the posterior portion of the gray matter in the spinal cord, which is right here, is responsible for the sensory function. If you remember this, then the rest will be easy. How the spinal nerve forms, et cetera, will become really easy, okay? So,
the anterior part is for what?
The anterior part is for motor function, okay? When I say motor function, I'm talking about the contraction of muscles, that's just part of motor. And then when I talk about sensory function, I'm talking about feelings, right? So pain, temperature, touch, vibration, all that are sensations. So that's part of the posterior portion of the gray matter of the spinal cord, okay? Right, so, spinal cord is part of the central nervous system, which is a relay hub, right? So information is coming in and going out. So information has to come in and go out of the gray matter, because that's the cell bodies of the neurons. So information that is going out technically should be motor information, right? Because this is the information that is going out to the periphery of the body for, let's say, muscle contraction, right? So that's motor information that has to go out. So information that is going out is going to go out of the gray matter through something called the ventral root, okay? You can call it the anterior root as well, okay? Ventral root. So motor information that is going out of the anterior portion of the gray matter of the spinal cord is motor information, okay? Responsible for muscle contraction. And then we have information coming into the gray matter, right? So as I said, it's a relay hub. So information has to come in and go out. We already talked about the information that is going out. Let's talk about the information that's coming in. That has to be technically and logically speaking, sensory information, right? So when I touch, let's say, the tip of my finger right here, the information has to be sent through the nerves into my spinal cord, right? So the spinal cord will receive that sensory information. So the sensory information logically should go to which part of the gray matter? Has to go to the posterior part, right? Because that's the sensory part of the spinal cord. So the information is going to the sensory information that enters the spinal cord is through something called the dorsal root. Okay, we have a ventral root, which is motor, and a dorsal root, which is sensory. Now, a little bit of exception to the rule: the cell bodies of the sensory neurons usually do not lie in the gray matter. They actually lie outside the spinal cord in something called the dorsal root ganglion. This is not super important for now, okay? But for now, just understand that we have a ventral root, which is motor or muscle contraction, and a dorsal root, which is sensory or sensations, all right? Now, the ventral root and the dorsal root are going to come together, okay? When they come together, they form the spinal nerve. See the green highlighted portion? This portion is the spinal nerve, okay? So when the ventral and the dorsal root come together, they form the spinal nerve. Now let's talk a little bit of some of the details, right? So ventral root is only motor information, right? If you see, the motor fibers are only red, and the dorsal root is only sensory information, which is shown in blue, right? So when the spinal nerve forms, it's actually mixed, which means it's a mixture of motor and sensory fibers, okay? So please remember that. Now, when the spinal nerve forms, it further divides into a ventral ramus, okay? Please differentiate between ramus and root, and a dorsal ramus, okay? An anterior branch and a posterior branch. The word ramus means branch, okay? So the spinal nerve, when it forms an anterior ramus or a ventral ramus and a dorsal ramus or a posterior ramus. And of course, both of them are mixed as well. By mixed, I mean motor plus sensory, because they are arising from the spinal nerve, which by itself is mixed, okay? Now, remember that, this might be a little difficult to understand. So I always give the analogy of the tree. If you take a tree and if you tilt it sideways, you'll find a tree has roots, okay? A tree has a trunk, a tree has branches, right? So the roots are analogous to the ventral and the dorsal roots. The trunk is analogous to the spinal nerve, and the rami, the ventral and the dorsal rami or ramus, are analogous to the branches of the tree, okay? So this, if you want to remember how the spinal nerve forms, just remember the tree, the roots, the trunk, and the branches, okay? So I hope the formation of the spinal nerve is clear. Okay, I'll move forward now. Of course, there's also something about the sympathetic fibers as well, which involve the gray and the white ramus. I don't believe it's important for the brachial plexus lecture. Okay, so let's talk about the brachial plexus. Brachial means upper limb in general, right? So the brachial plexus has to do something with the upper limb. The word plexus means to plait, to form a braid, okay? When you form a braid with your hair, It's basically a network of hair fibers, correct? And so a plexus is a network of something. So whenever you hear the word plexus, think of the word network, okay? When you think of something, when you think of a network, you have to think that the things inside that network are interconnected to each other. Okay, now a plexus could be a connection or a network or interconnected nerves, or it could be blood vessels as well. But of course, brachial plexus is a interconnected network of nerves. Okay, so when you think of the word plexus, as I said, remember the word network. And two other words I want you to remember are connections and branches. Okay, connections and branches. So any plexus, any nerve plexus that you look at inside the body, we have the lumbosacral plexus, we have the cervical plexus, and of course we have our brachial plexus. You're going to find that they're made up of a lot of connections and a lot of branches. So when we talk about the formation of the brachial plexus, just remember that we're going to expect connections to be there and branches to be there as well. Okay, so this is something that I would say to people who are not already familiar with some of the details in the lecture, but you guys should already know this by now, okay? Because again, this is just a review lecture. Okay, so when we come to the formation of the brachial plexus, we also have to review the rest of the spinal nerves. Okay, spinal nerves are nerves. We talked about how the spinal nerve forms, right? And they're coming out of the spinal cord. We have 31 pairs of spinal nerves, which means on the right and on the left. Okay, and they're coming out of the different levels of the spinal cord, right? And to make stuff easier, I always tell people to remember or think of the spinal cord as a multi-story building. Okay, a multi-story building in which has different floors. Just like that, our spinal cord has different floors. Okay, it has the cervical floor, it has the thoracic floor, it has the lumbar floor, and then it has the sacral floor. Okay, these are just sections of the spinal cord which are named according to the area of the body in which they lie, right? So cervical is cervix. The word cervix means neck. So they're at the very top. Then we have thoracic, which is related to the thorax. So they're kind of in the middle. Then we have lumbar, which is your lower back. So lumbar spinal cord is over there. And then we have sacral and coccygeal, which I really don't have, an analogy for you guys to remember that. But just remember, we have cervical, thoracic, lumbar, and sacral spinal cord. And out of these floors or sections of the spinal cord, we have spinal nerves coming out. Okay, so we have cervical spinal nerves, we have thoracic spinal nerves, we have lumbar spinal nerves, and then we have sacral spinal nerves. Okay, and they're named according to the area of the spinal cord that they live at, the floor of the spinal cord that they live at, right? So when you name a spinal nerve, right, it consists of a letter, so alphabet and a number. Okay, an alphabet and a number. The alphabet is the first letter of the name of the section of the spinal cord that the spinal nerve is coming out from. So let's say if it's cervical, so that spinal nerve will be C, thoracic is T, and so on and so forth. I think it's easy for you guys to understand that part. The number is simply the order of the spinal nerve from the top. So we have C1, then we have C2, C3, C4, C5, etc., etc. And same goes for thoracic, same goes for lumbar, okay? We have 8 pairs of cervical spinal nerves, we have 12 pairs of thoracic spinal nerves, we have 5 pairs of lumbar, and we have 5 pairs of sacral, and we also have 1 pair of coccygeal spinal nerves. Okay, so in total there are 31 pairs of the spinal nerves. So this is, if you count them, there are 31 pairs, one on the they're on the right and the left side. Okay, was that clear? Is this part clear? I hope you guys already know this, and I'm just going a little fast so we can get to the main point. Any questions here?
Thank you.
Oh, okay.
You're welcome. All good? All right. All right. Now, this is a very important thing. One second, please. Now, this is a very important thing that I want you guys to remember forever. Okay, not just for this lecture right now. So remember when we talked about the formation of the spinal nerve, how the ventral root and the dorsal root come together to form the spinal nerve, which then branches off into a ventral ramus and a dorsal ramus. Okay, now just remember, dorsal rami of any spinal nerve, cervical, thoracic, lumbar, whatever, never form any nerve plexuses. Okay, it's a rule of thumb. The dorsal rami of any spinal nerve never forms any plexus. They only supply the muscles and skin of the back, and they have other functions which we don't really care about right now. The ventral rami, on the other hand, are super important in the formation of the nerve plexuses that we have in our body, okay? Now, do all the ventral rami of all the spinal nerves form nerve plexuses? No. Just remember that all the ventral rami of all the spinal nerves form nerve plexuses except for the thoracic ventral rami. So the ventral rami that arise from nerves T2, T3, T4 up until T11, and according to some sources T12, they do not form nerve plexuses. Anything above that and anything below that, they contribute to formation of nerve plexuses, okay? So for instance, you know, we have the cervical plexus, we have the brachial plexus, and then we have the thoracolumbar plexus towards the end. The ventral rami of the spinal nerves are contributing to the formation of those nerve plexuses and not the dorsal rami. Is this part clear? And please remember this forever, Yani, okay?
Can you repeat, please?
Sure. Now, when we talked about the formation of the spinal nerve, right, we said that the spinal nerve further branches off into a ventral ramus and a dorsal ramus. The word ramus means a branch, simply, right? Now, just remember that the dorsal ramus of any spinal nerve never forms any nerve plexus, okay? Now, this is just a basic fact, Yani. This is not specifically related to the brachial plexus, but this is a basic fact. The ventral rami, on the other hand, which are the anterior branches of the spinal nerve, they always form nerve plexuses except for the ventral rami of spinal nerves T2 to T11 or T12, okay? Is that clear?
Yeah, thank you.
Okay, you're welcome. So what do the ventral rami of T2 to T12 do? They form the intercostal nerves, which are the nerves in between your ribs. You will learn about these when you talk about the cardiovascular and respiratory system in your next semester. Okay, so don't worry about it for now. Okay, ideally I would give you a break, but this is a review lecture, so we just move on. So this is a question for you guys, and I would like you to type the answer in the chat. A spinal nerve is formed by the union of blank and blank. Is it A, B, C, or D? Excellent, very good. So the correct answer is C, okay? Right. Just remember the tree, right? So the roots form the trunk and trunk gives off the branches. Okay, so now we're going to talk about the brachial plexus. A quick overview of the brachial plexus is that the brachial plexus is formed by the anterior or the ventral rami of C5 to T1 spinal nerves, okay? And even if I did not say that it's formed by the anterior rami, it's an understood fact because the dorsal rami never form any nerve plexuses anyways, okay? But it's good to keep that in mind. The function of the brachial plexus is to innervate your upper limb, as you guys already know. It arises from the spinal cord right here. It runs from medial to lateral, okay? It runs from medial to lateral. It goes under your clavicle and over your rib cage, and then it goes more laterally to supply your upper limb. And we're going to discuss and review, Yani, or like review how it forms and what are the main nerves that come out of it, okay? Now, the components of the brachial plexus, as you can see here, it's a bunch of connections, a bunch of branches, right? A network that is sometimes hard to remember. So in order to make stuff easy, they have divided the brachial plexus into components, right, that run from medial to lateral. So we have roots, trunks, division, cords, and then terminal branches that just help you organize the brachial plexus in a much easier way, and of course, remember it as well. So and you guys already know this, right? So we have running from medial to lateral, we have roots, then trunks, then divisions, then cords, then branches. And this is the brachial plexus right here. So we have the roots, which are the most medial component of the brachial plexus. And as we go laterally, we form the trunks, the divisions, the cords, and then in the end, we have the branches, the terminal branches, right? And we'll discuss that, how that happens in a bit. Now, in order for you to remember, these important 4 to 5 components of the brachial plexus, you can remember this mnemonic. Read that damn cadaver book. It has never failed me to remember these 5 components. And again, remembering these 5 components will make stuff easier later on as well. So this is the mnemonic that you guys can use, and any other one that you have. Okay. Right. So this is a brachial plexus again. Just a quick review on a cadaveric photo. We have the roots, then we have the trunks, then we have the divisions, then we have the cords, and then we have the terminal branches. The word terminal means at the very end. Okay. So these are the branches that you can say finish the brachial plexus. Okay. Again, this is what you might find in your anatomy textbooks. We have the roots, the trunks, the divisions, cords, and the and the terminal branches. This is what it might look like down in the cadaveric lab. It's very complicated. So to make stuff easy, we're going to build the schematic diagram. Okay. So what I've put right here is the roots to the terminal branches, the 5 components of the brachial plexus. Of course, this is just a schematic diagram, simplification of reality, but this will help you understand it better. Remember, the roots are the most medial structure and the terminal branches are the most lateral structures. So we're going from medial to lateral. We're building the brachial plexus. And as I always also said, that when you think of the word plexus, remember the word connections and branches. So this is what, you know, we're going to apply when we review the formation of the brachial plexus. All right. So these are the roots of C5 to T1. Is that a correct sentence? These are the roots of C5 to T1. Yes. Exactly, Agent O2. I don't know why I have to be very secretive, but you are absolutely right. When we say roots of the spinal nerve, that is a different thing. When we say roots of the brachial plexus, that is a different thing. Okay, you have to understand the difference between the two. Remember that the roots of the brachial plexus are basically the ventral rami of the spinal nerves C5 to T1. Okay, the ventral roots or the dorsal roots have nothing to do with the brachial plexus. We're talking about the ventral rami of the spinal nerve C5 to T1 that form the brachial plexus, right? So if we go back a little bit and we look at this image right here, right? So when I say roots of C5 to T1, I refer to these roots, right? These ventral and dorsal roots. These are not what from the brachial plexus. Of course, they contribute the nerve fibers or whatever, but the thing that is directly involved in the formation of the brachial plexus is the ventral rami of C5, C6, C7, C8, and T1. Okay, so when I say the roots of the brachial plexus, I mean the ventral rami of C5 to T1 spinal nerves. Okay, is that clear? So brachial plexus is only from ventral rami that is formed by the ventral root and the dorsal root. Exactly, you're right. Okay, excellent. Okay, because this is something that always icked me, you know, back then. What's the difference between roots of the spinal nerve and what's root of the brachial plexus? They're different things. Okay. Anywho, so let's build up the brachial plexus one by one. Remember the word connections and branches, right? So things are going to connect together and then things are going to branch out. So now when I say the roots of the brachial plexus, when I say the word roots from now onwards, I mean the roots of the brachial plexus. Okay, so don't confuse yourself. Whenever I say roots from now on, I just mean roots of the brachial plexus. I will not say ventral rami or roots of the brachial plexus because that takes time. So roots, right? So roots, let's see what are the roots here. We have C5 to T1, right? Remember that C5 and C6 roots are going to join together. C8 and T1 roots are going to join together, and C7 is going to continue alone. And that's simple enough to understand, right? We have 5 roots of the brachial plexus. The first 2 will connect together. The last 2 will connect together, and the middle one will continue alone, right? So C5, C6 together, C8, T1 together, and C7 will continue alone. So these are connections, remember, okay? Next, when the roots connect together, they form the next portion of the brachial plexus, which is the trunks, right? So the trunks are superior, middle, and inferior, and they're named very simply. Superior is on the top, inferior is at the bottom, and middle is in the middle, okay? Simple enough to understand, no any extra logic here, no hardcore maths here, okay? Superior, middle, inferior, simple as that. Superior is on the top and inferior is at the bottom, middle is in the middle. Now, trunks are going to divide or branch out into the next portion of the brachial plexus, which is known as divisions, right? And each of the trunks will give us 2 divisions, an anterior division and a posterior division, right? So all of these are going to give us anterior and posterior divisions, okay? Anterior, posterior, anterior, posterior, anterior, and posterior, right? Now, why is it called anterior? Why is it called posterior? Simple, because anterior is in the front and posterior is at the back. Simple as that. Okay, nothing any hardcore, nothing difficult to understand there. Now, the divisions are going to connect together to form the next portion of the brachial plexus, which is known as cords. Okay, and I just want to emphasize on the fact that things are connecting together and things are branching out, which is the basic principle that I told you in the very beginning, right? Anywho, divisions are going to connect together to form the cords. Now, the anterior divisions of superior and the middle cord, the middle trunks are going to join together to form the lateral cord, okay? The posterior divisions of all the trunks are going to join together to form the posterior cord, okay? And the anterior division of the inferior trunk is going to continue alone as the medial cord, okay? Again, the anterior divisions of the first two trunks, superior and middle, are going to join together to form the lateral cord. The posterior divisions of all of the trunks will continue to form the posterior cord, and that's easy to remember, right? All the posterior cords, all the posterior divisions continue are joined together to form the posterior cord, and the anterior division of the inferior trunk is going to continue alone as the medial cord. Now, lateral, posterior, and medial. Now, these three together don't make sense, right? If it was just lateral and medial, that would make sense, right? Because the lateral cord is more lateral, the medial cord is more medial. But why they have, added something called posterior? Because these lateral, medial, and posterior names are given because of the relation of the cords to a particular structure, okay? And that structure is the second part of the axillary artery, okay? This is the second part of the axillary artery. So the lateral cord is lateral to the second part of the axillary artery. The medial cord is medial to the second part of the axillary artery. And the posterior cord is posterior to the second part of the axillary artery. This is why they have been giving these names, okay? The names before were just simple logical names. Superior is on the top, inferior is at the bottom, middle is in the middle, anterior is in front, and posterior is at the back. But here, when they've given lateral, medial, and posterior names to these cords, this is because they are in relation to a specific structure, and that is the second part of the axillary artery. I hope your misconception is cleared out, Shamoun, okay? So the cords are related to the axillary artery, not the divisions, okay? Now, the cords are now going to branch out to form the terminal branches. Again, remember, divisions and branches, connections and branches, right? So the cords are now going to form the terminal branches. So what are those terminal branches? These are the big nerves. These are very important nerves that you have to know for your exams, okay? So the lateral cord will form the musculocutaneous nerve. This is not the musculoskeletal nerve. This is the musculocutaneous nerve, okay? And then it also gives another branch. We'll talk about that branch later on. Let's skip the posterior cord for now. Let's go directly to the medial cord. The medial cord will give off the ulnar nerve, okay? And it'll also give off another branch that will join the extra branch that was given off by the lateral cord. These two branches are going to join together to form the median nerve, median with an N, okay? Not medial nerve, median nerve, okay? So this is known as the lateral contribution to the median nerve, and this is known as the medial contribution to the median nerve. Why is it called lateral contribution? Because it's coming from the lateral cord. Why is it called the medial contribution? Because it's coming from the medial cord. And why are they known as contributions? Because they contribute to the formation of the median nerve, okay? So far we have talked about three big nerves. Lastly, the posterior cord will give up two branches. One of them is the radial nerve, and the other one is the axillary nerve. So these are the 1, 2, 3, 4, 5 terminal branches of the brachial plexus. Was this clear? Was this formation of the brachial plexus clear? And I hope it was a good review for the rest of y'all.
Yes, it was clear.
Okay, thank you very much. Okay. So the type of questions that might come from this slide right here is basic, recall questions. So they might ask, what forms the superior trunk? What forms the middle trunk? What forms the inferior trunk? The posterior cord of the brachial plexus is formed by the union of blank. So that is the posterior divisions of all the trunks, right? They might ask, the cords of the brachial plexus are related to what structure? And that is the second part of the axillary artery. They might ask, what branches does the posterior cord give off? So that's the axillary nerve and the radial nerve. So simple recall questions might come up from this slide here. Okay. All right. And of course, there's the infamous M, which is right here, which is from the musculocutaneous, the lateral contribution to the median nerve. The median nerve the medial contribution to the median nerve, and the ulnar nerve. So this is the M that you might find down in the anatomy lab to identify structures. So basically, you know, when you want to identify the brachial plexus in the anatomy lab, it's very hard to do it. So what I suggest that you guys do, and I think it's too late for me to recommend that now, given that your exam is nearby. You start at the very end. You start at the terminal branches. You find the M, and then you go back. Okay. You find the M, and then you go back. By the way, are you guys having your midterm or your final on Thursday?
Midterm.
Midterm. Okay. Give me 1 second. I'm just gonna. Okay. Okay, midterm, huh? Okay. All right. So just want to, I don't know if you were taught this, I didn't find this in your lecture, but the axillary artery is composed of 3 parts, okay? The first, the second, and the third part. And it is divided into these 3 parts and anatomically by a muscle called the pectoralis minor muscle. So this is the pectoralis minor muscle right here. And the axillary artery is divided into 3 parts by it. Any part of the axillary artery that is before is known as the first segment. Any part of the axillary artery that's just underneath the pectoralis minor is known as the second segment. And any part that is after it is known as the third segment. Okay, so these are the 3 parts of the axillary artery. When I say parts of the axillary artery, that is because they're divided into these parts by the pectoralis minor. By the way, do you have to know the branches of these arteries for your exam?
Yes, we do.
Okay, best of luck then. So, I mean, I guess this is a very good slide here that I found on the internet, is that the first segment of the axillary artery will give off 1 branch, the second will give off 2 branches, and the third will give off 3 branches, okay? Now, as to how to memorize them, as is one of your colleagues' question, is honestly, you have to look at the diagram, okay, and see where the arteries are. Now, I just made this up on the spot. First segment is at the very top, right? So it has to be something superior, and it's thoracic because, you know, it's in the thorax on the top. Second segment will have the lateral thoracic because it's more lateral. If you see, the axillary artery is going downwards, but also going more laterally, right? So it's not just going straight down, it's going like this. So it's going inferior laterally, right? So the second branch will give off something lateral, so lateral thoracic branch. The third segment will give off the, so when you think of this third segment, just think of the humeral head. So the arteries are on the humeral head, have the anterior and posterior circumflex humeral arteries, and we have the other arteries. I hope this might help you understand it or remember it better, but I don't know any other particular way. I'm sorry. You might have some mnemonics. I particularly don't know of any mnemonics that might help you, but yeah, that's about it. You know, your exam is going to be multiple choice, right? So when it comes to it, you might be able to use it. Trust me, it's in the back of your head. It might be hard repeating it, you know, on the spot, but when it comes to the exam, you will have multiple choices, and you might find it much easier to recognize the correct answer. Okay. All right. Next up, we have what I call the purple branches. The purple branches they're called purple branches because I'm going to color them purple in my schematic diagram. So these branches are basically different branches that are coming off of the different parts of the brachial plexus that are also relatively important. A few of them are more important than the others. So we have branches coming off of the roots of the brachial plexus, right? We have the dorsal scapular nerve, which is basically supplying you, I think, your rhomboids and some of the other neck muscles. Then we have the super important nerves, which is, by the way, the dorsal scapular nerve is coming out of the C5 root of the brachial plexus. Then we have a nerve coming out from the C5, C6, and C7 root of the brachial plexus known as the long thoracic nerve. And this is a very favorite nerves of the professors because they love to ask questions about it. And lastly, we have the contribution to the phrenic nerve, which is coming from the C5 root of the brachial plexus. Okay, the phrenic nerve is basically the nerve that helps contract your diaphragm. This is more of cardiovascular respiratory system, again, next semester. my advice is that you guys really focus on the long thoracic nerve and know that the long thoracic nerve comes off from C5, C6, and C7. Okay. From the trunks of the brachial plexus, we have the suprascapular nerve, which, if I'm not mistaken, supplies the supraspinatus and meatus, which are two of your rotator cuff muscles. And then we have the nerve to the subclavius. Innervations of what? Long thoracic, no, sorry, I forgot to mention. The innervation of the long thoracic nerve is the serratus anterior muscle, which is responsible for two things. Number one is to stick your scapula to your thoracic wall, is to raise your arm above or abduct your arm above 90 degrees. Okay. We'll focus on it when it comes to injuries in the end. Okay. Then we have the nerve to subclavius. I don't believe this is important at all. But the suprascapular nerve you should know. I think you might have reviewed it in your shoulder anatomy lecture. Okay.
Doesn't the thoracic anterior adduct?
Can you please repeat that?
Doesn't the thoracic anterior adduct? Doesn't abduct?
From what I know, it helps you abduct your arm above 90 degrees, and this is why people who have long thoracic nerve injuries, they have difficulties like combing their hair and performing overhead activities. If I'm wrong, please do let me know. Let me search. I believe that it is abduction, not adduction. Abduction, so the thing that I said. The deltoid muscle also helps in abduction, not adduction. Okay. All right. Then we have there are no branches coming out of the divisions. Then we have the cords that give off the lateral pectoral nerve, which is responsible for this for supplying your pectoralis major and also your minor. Then we have the superior subscapular nerve. I'm forgetting what exactly it supplies. And we have the thoracodorsal nerve, which supplies your latissimus dorsi. It is also known as the nerve to latissimus dorsi. And then we have the inferior subscapular nerve. Okay, I believe the superior subscapular supplies your subscapularis, and inferior subscapular supplies your teres major, if I'm not mistaken. All right. Then from the medial cord, we have the medial pectoral nerve, okay, which supplies your also pectoralis minor and also your major. Then we have the medial cutaneous nerve of the arm. Just like the name suggests, it is a sensory nerve which supplies the sensations on the medial surface of your arm. And we have the medial cutaneous nerve of your forearm, which supplies the medial sensation on the medial surface of your forearm. Okay. All right. So these are the purple branches. The one that I think that are super important is the long thoracic nerve. Okay. Then we have the, I believe suprascapular nerve is important, and you might have reviewed it in your shoulder lecture. Nerve to subclavius is not important. I don't even know what the subclavius does, and I don't think you do. The lateral pectoral nerve is important. The medial pectoral nerve is important, okay, because they supply your pectoralis muscles. The thoracodorsal nerve is important, and it's always good to keep in mind the sensation, the sensory innervation of the upper limb. Okay, and I'll have a slide to review that towards then. I'll try to make it really easy. Any questions from here? All right. So this is, I believe, the diagram from your lecture, which I have a little trouble understanding, but I think I covered everything that's in here. Okay. The only thing that I did not focus on till now is the root values of these nerves that have been put in the lecture. We'll talk about these towards the end. No, like towards the middle, not the end. Okay. What form the superior trunk of the brachial plexus? Please answer A, B, C, or D in the chat. And tell these type of questions might come in your exam. These are simple review recall questions that are based on your simple anatomy. Okay. We have an A. Very good. Excellent. Correct answer is A. Right. Ventral roots of C5 to C6 from the C5, C6 spinal nerves, but not the brachial plexus. Dorsal rami never form any plexuses, and ventral rami of C5, C6, C7 is not correct because C7 does not contribute to the superior trunk. Hope that is clear. Okay, so I want to apply the schematic diagram that we've learned onto the diagram that you might find in your anatomy textbooks. Okay, and also talk about the axillary artery a little bit. Okay, so as you can see here, we have this is the midline, this is the medial, the most midline structure, which is the spinal cord inside your vertebrae, and out comes the ventral rami of C5 to T1. These are the ventral rami of C5 to T1. Okay, they connect to form the next portion, which are the superior, middle, and inferior trunks, which you will find here: superior, middle, and inferior trunks. Okay, and then the trunks divide to form the branches, which are anterior and posterior, which are not exactly shown because of the clavicle and the subclavius. Then we have the cords, which are called lateral, posterior, medial because of this structure in the middle, which is the axillary artery. So lateral is lateral, posterior is at the back, and medial is medial. This is the medial one right here. Okay, sorry, this one right here. And then they form the terminal branches. Okay, so here is your M. The lateral portion of your M is your musculocutaneous nerve. Why? Because the musculocutaneous nerve is coming out of the lateral cord, which you can remember is more lateral. Okay, then we have the ulnar nerve, which is the middle of the M, and then we have the ulnar. So we have the median nerve, which is the middle of the M, and then we have the ulnar nerve, which is the medial portion of that M that we talked about. Okay, and then you will find the rest of the branches coming out of the different portions. So, for instance, where's the long thoracic nerve? This is the long thoracic nerve. Okay, see, it's super long, coming from C5, C6, and C7. I hope the diagram is a little more clear now. Okay. Now, the root values of nerves. This is something that I had trouble remembering, understanding. So I'll try to clear out some misconception that you guys might have, right? So if you look at if you go back to the first sorry, so ulnar is most medial, musculocutaneous is lateral. Yes, you can say that. All right, so when you come to, go back to the first slide that I had before introducing myself, that when we have a nerve, right, let's say a big nerve, is a bundle of neurons, right? So it's a bundle of nerve fibers. And these nerve fibers can be coming from anywhere, okay? Of course, when you form the plexus, the nerve fibers are coming from predictable origins, right? So when we talk about musculocutaneous, ulnar, radial, median, axillary nerves, these are all nerves that are coming out of the brachial plexus, right? So the fibers of these nerves must be originating from the spinal nerves C5 to T1 for sure, right? But C5 to T1 C5 to T1 spinal nerves do not contribute all of their fibers to all of these nerves, right? Because musculocutaneous has fibers from C5, C6, and C7, but sorry, axillary only has from C5 and C6, right? So these are known as I call them the root values of nerves. Basically, it means where does this nerve, okay, let me rephrase that. When I say root value, is basically the nerve fibers of the nerve of this particular nerve, where are they originating from in terms of which spinal nerve are they coming from, okay? Now, if you look at the brachial plexus, right? You might think, let's logically figure that out. So let me take the example of the musculocutaneous nerve, right? The musculocutaneous nerve, if you trace it back, it's coming from the lateral cord. The lateral cord is coming from the anterior divisions of the superior and the middle trunk. And then the superior and the middle trunk are coming from C5, C6, and C7, right? And that makes sense. If you go back and you look at the root value of musculocutaneous nerve, it's C5, C6, C7. Right, so C5 and C6 and C7 ventral rami contribute the nerve fibers into the musculocutaneous nerve. Now let's take another example. Let's take the example of the axillary nerve. Axillary nerve is coming from the posterior cord. The posterior cord is coming from the posterior divisions of all the trunks, and all the trunks are coming from all the roots of the brachial plexus, right? So technically, logically speaking, if I trace back axillary nerve, it should have contributions of nerve fibers coming from C5, C6, C7, C8, and T1, right? But if I go back and look at the root value, I see that it's only coming from C5 and C6, right? So this tracing back method does not work. Okay, so do not rely on it. At the end of the day, you kind of just have to memorize the root values of these nerves. Now, you might ask, why do I have to memorize them? Why are they important? I'll give you one example, right? Let's say that there is a, I think you guys know what's a disc, right? Nucleus pulposus, annulus fibrosus. I don't remember it exactly, but I think this is, if I'm saying it correctly, we have a disc that is between the vertebrae, right? Now, sometimes the central portion of that disc, which I believe is called nucleus pulposus, herniates, right? It herniates, which means it protrudes out of its normal place, and it impinges or it compresses on nerve roots, right? Let's say this is C5, for instance. Okay, although from the diagram it seems more like lumbar, let's call it C5. Now, if it's compressing C5 and I see that on, let's say, the MRI scan, I can predict that any nerve which has its contribution from C5, any nerve that has its nerve fibers coming from C5 will be affected, right? So if I go back and see, so musculocutaneous will be affected, radial might be affected, axillary might be affected, but ulnar won't be affected because it has no C5 contributions, right? So the functions of musculocutaneous and radial nerves will be affected. And same goes for the other, the more important thing for you guys, the brachial plexus injuries. If I damage C5 and C6, any nerve that has C5 and C6 fibers, and by that I mean any nerve of which the fibers are arising from C5 and C6 will be affected. And hence, if you go more downstream, if you go more down there, you'll find that the functions of those nerves will be affected. Okay, so this is why you have to know and memorize the root values of at least the major nerves. Okay, I'm not saying you go and memorize the root values of subscapular nerve or whatever, right? So the major ones: musculocutaneous, ulnar, radial, axillary, median, and of course, long thoracic. What is the root value of long thoracic nerve?
C5, 6, 7.
Excellent. C5, C6, and C7, because it's arising from there. The fibers from coming from here, here, and here have to contribute to the long thoracic nerve. Okay. All right. I hope everything is clear so far. Any questions? Any queries? Huh? Excellent. Very good. Okay, question: what are the chords of the brachial plexus associated with? A, B, C, or D?
A.
Correct. The answer is A, and specifically the second part of the axillary artery. Okay. Okay. So now, before we talk about the before we move forward, I'd like to just remind you guys that nerves have motor functions and sensory functions. Motor functions, basically, for you guys at this level, just remember that it stands for innervation of the muscles, which help the movement of those muscles. And sensory function is basically supplying the skin, which takes up sensations, right? So touch, temperature, pain, all that stuff. And a nerve can be simply motor nerve or simply sensory nerve, or it could be a mixed nerve, which means it has both motor and sensory functions. From this diagram, what is an example of a pure motor nerve? Diagram. Ventral root, yes. So ventral root itself is a nerve, right? Because it's a bundle of neurons, so it's a nerve, and it's pure motor. A pure sensory nerve would be the dorsal root. Okay, spinal nerve is not a pure motor or pure sensory. Okay, spinal nerve is a mixed nerve because it is said it is formed by the union of ventral and dorsal roots, which means it has both motor fibers and sensory fibers. Okay, spinal nerve is the best example of a mixed nerve. Okay, please remember that. Okay, so now the reason I said this is because now we're going to discuss the main terminal branches of the brachial plexus and their functions. So I want you guys to just remember that most of the terminal branches are mixed nerves. So they have both motor function and sensory functions, okay? So we have a total of 16 nerves of the brachial plexus. I'll just mainly be discussing the 5 terminal branches, okay? First up, we have the musculocutaneous nerve. It has a sensory function, has a motor function, okay? Now, you guys might have trouble remembering what nerve supplies what muscle, etc., etc. So let's talk about some general rules. Okay, when you think of the musculocutaneous nerve, what comes to mind? What action comes to mind?
The biceps, the brachialis.
Yes, of course, the muscles. But what function comes to mind? Arm flexion, exactly. Arm flexion and elbow flexion, right? So the muscles that you correctly mentioned are, of course, going to be in action, but the function that comes to mind is arm flexion and elbow flexion, right? So if you know the muscles that cause arm flexion and elbow flexion, you can infer that musculocutaneous nerve must supply most of them, okay? So the musculocutaneous nerve supplies coracobrachialis, biceps, and brachialis, okay? That's easy enough to understand. And then musculocutaneous, that's its motor function. Another way you can remember is that musculocutaneous nerve supplies the anterior compartment of the arm, okay? Then we have the sensory function of the musculocutaneous nerve, which is basically to supply the lateral portion of the skin of your forearm, okay? And this is because it has a branch called the lateral antebrachial cutaneous nerve. When you say antebrachial, that basically means forearm, and cutaneous nerve basically means a sensory nerve. So the sensory function of the musculocutaneous nerve is via this branch, which supplies the lateral portion of your forearm, okay? The lateral portion of your forearm. Next up, we have the median nerve, okay? The median nerve. Okay, lots of people, they confuse themselves, right? The median nerve should be medial in the forearm. That is not correct. Median nerve runs more laterally. The ulnar nerve is more medial in the forearm. So please, don't confuse yourself between the two. Median nerve is also a mixed nerve. It has a motor function, has a sensory function. The motor function of the median nerve, generally speaking, is to supply the anterior compartment of your forearm, the anterior compartment of your forearm. And what is the function of the anterior compartment of your forearm?
Flexion of the forearm. Flexion.
Exactly, flexion of which joint?
Radial nerve.
Flexion of which joint? Flexions of the wrists and the fingers. Very good. Okay, so the median nerve, just remember, when you think of the median nerve, the function that should come to your mind is flexion and of the wrist and the fingers. Okay, and so it must supply the anterior compartment of your forearm. There are two exceptions. Okay, what are those exceptions? Can anyone tell me? Have a midterm on Thursday.
The thumb?
I'm talking about the anterior component of the forearm, which, very good. So one of them is, so Salma has the perfect answer, flexor carpi ulnaris, and the half of flexor digitorum profundus. Very good, Salma. Okay, so so the median nerve supplies all of the muscles of the anterior compartment of the forearm, except for the flexor carpi ulnaris, which logically speaking must be supplied by the ulnar nerve, and the medial half of the flexor digitorum profundus, okay, which is supplied also by the ulnar nerve. I'm just reviewing the muscles of the different compartments. This is not the brachial plexus per se, but it's for you guys to review it before your exam. And also the median nerve supplies the muscles of the hand, okay? I hope you guys, is the hand coming in your exam? Because usually they don't include it in the midterm.
Yes.
Okay, great. So you guys should remember what muscles of the hand is supplied by the median nerve, okay? Okay, the sensory function of the median nerve is this in the green portion. So the lateral 3.5 digits, so your thumb, your index, and half of your middle, 3.5. So thumb, index, middle, and half of your ring finger, and the area of the palm that is associated with that area. So that is supplied by your median nerve. It also supplies a little bit of the dorsal surface of your hand, as you can see right here. Okay, the sensory supply of the hand is an extremely high yield topic. They love to ask about it in the exam. Okay, whether it is an OSP or whether it's regular MCQ SAQs. So please remember the sensory supply of the hand. Next up, we have the ulnar nerve, which is also a mixed nerve, has a motor function and a sensory function. The motor function is to supply the two exceptions of the anterior forearm muscles that the median nerve did not supply, and this is the flexor carpi ulnaris and the medial portion of the flexor digitorum profundus, and it supplies most of the hand muscles. Okay, Then we have the sensory function of the ulnar nerve, which is basically the medial 1.5 digits. So that's your pinky and your half of the ring finger and area of the palm that is associated with it. On the dorsal surface as well, it supplies the same area. Okay. Then we have the radial nerve. When you think of the radial nerve, what comes to your mind? What function comes to your mind? Just one word. Extension, exactly. Extension of the arm, extension of the elbow, extension of the fingers. Okay. All the extensors are supplied mainly by the radial nerve. And so this is what you should remember. The radial nerve is the nerve that is at the back. Okay, so it's supplying all the posterior compartment of your arm, which is your triceps, posterior compartment of your forearm, which is basically your extensor compartment of your forearm, which helps in the extension of the wrist and the fingers. Okay, so when you think of the radial nerve, think of the nerve that is at the back. Okay, that is supplying all the muscles at the back that help in extension. This is a kind of a way to remember it. Sensory function of the radial nerve, since this is the nerve at the back, it also supplies all the skin at the back. It supplies the skin at the back of your arm, of your forearm, and of your hand. Okay, the area that was not supplied by the median or the ulnar nerve is supplied by the radial nerve. I hope that makes it clear. All right. Last up, we have the axillary nerve, which is also a mixed nerve. It supplies the deltoid muscle, and it also supplies the teres minor muscle. Okay, and these are muscles that are involved in abduction of your arm. The sensory function of the axillary nerve is also to supply the shoulder area. Okay, the shoulder area. Now, why do you need to know the sensory and the motor functions? Because they might give you clues in the question that the patient lost sensation on, let's say, the lateral portion of his shoulder. So axillary nerve might be damaged. If the patient lost sensation to their index finger on the palmar surface, so the median nerve is affected. If the patient lost sensation to, let's say, the posterior arm, radial nerve is affected, right? So you need to use these basic anatomy clues to answer the questions in your exam. Okay. And same goes for the motor functions. Okay. Now, just a review of the cutaneous innervation of the hand or the sensory innervation of the hand. Remember that the lateral remember the thumb is more lateral. Okay, so the lateral 3.5 digits are supplied by the median nerve on the palmar surface, and on the palmar surface, the medial 1.5 digits are supplied by the ulnar nerve. On the dorsal surface, there is a portion of the lateral 3.5 digits that is supplied by the median nerve, but most is supplied by the radial nerve, and the rest is supplied by the ulnar nerve. Okay, please review the innervation of the hand. Now let's review quickly the innervation of the upper limb in general. Okay, I won't review the hand now. I'll just review the arm and the forearm. So forget about this area. Forget about the upper chest area. From here. So lateral shoulder has to be the axillary nerve, right? The axillary nerve. I don't think you need to know the specific branches. The axillary nerve, right? Now let's come more towards, so we're done with the shoulder, let's go down to the arm. Let's divide. We have medial arm, and then we have lateral arm. The lateral arm is mostly supplied by the radial nerve. Lateral and posterior is supplied by the radial nerve. And the medial arm is supplied by the medial cutaneous nerve of the arm, right? Which comes off what cord of the brachial plexus? The medial cord of the brachial plexus, right? So this is supplied by the medial cutaneous nerve of the arm. Then we go to the forearm. Okay. Oh, sorry. Let's talk about the posterior arm, which is easy enough to understand. That's also a radial nerve. So in the arm, we have medial, lateral, and posterior. Posterior is radial nerve, lateral is radial nerve, and medial is medial cutaneous nerve of the arm. Okay. Now let's go down to the forearm. Again, medial, lateral in the anterior surface, and then the posterior surface altogether. Most of the posterior surface is by the radial nerve, okay, as you can see here. And then medial surface is by the medial cutaneous nerve of the forearm, or the medial antebrachial cutaneous nerve, which also comes off of the medial cord of the brachial plexus. And the lateral is by the musculocutaneous nerve, by the lateral antebrachial cutaneous nerve, right? So again, forearm, medial, lateral, posterior. Medial is by the medial cutaneous nerve of the forearm. Lateral is by the musculocutaneous nerve, and posterior is by a combination of these two plus the radial nerve, okay? And then the hand, we already talked about it. So does that make stuff a little more clearer? And if there's any question, feel free to ask. Okay. Okay, so let's repeat. So if you want to remember the cutaneous innervation or the sensory innervation of your upper limb, which I think is not super important, but I think is important because it might give you clues in a big question stem, right? So let's start with the shoulder, right? So shoulder, axillary nerve, that's it. Coming down to the arm, we divide the arm into medial, lateral, and posterior. The medial arm is by the medial cutaneous nerve of the arm, okay, which comes off of the medial cord of the brachial plexus. The lateral portion of the arm and the posterior portion of the arm are both supplied by the radial nerve. All right, let's go down to the forearm. Medial, lateral, posterior. Medial is by the medial cutaneous nerve of the forearm, which is coming from the medial cord of the brachial plexus. This was one of the purple branches that we talked about. The lateral is by the musculocutaneous nerve, and the posterior is a combination of these two plus the radial nerve, okay? And the hand we already talked about. A question which says, do we need to know the dermatomes? Honestly, I'm not too sure. I do not remember that dermatomes were super important in first year, but they were important in second year and fifth year. So I'm not sure. But if you want, the dermatomes of the hand are easy to remember. Okay, I'll give you a quick trick to remember this, right? So on the hand, we have the C6, C7, and C8. So if you look at C6, it basically is supplying your thumb and your index finger. If you kind of do this, right? If you kind of do this, it makes a 6, right? So that's a 6. So that's C6, right? C7 is in the middle, which you can remember by the Arabic 7 numerical, which is this. This is how you write the Arabic 7, right? So that's C7. So this is the the index and the ring finger are making that kind of 7, and the rest is C8. But the rest of the dermatomes, I don't think is super important for you to remember, honestly. Were you taught dermatomes in details? Alas, then no need, my opinion. All right. Now we're going to go to the important clinical part of the lecture, which is the injuries to the brachial plexus. Okay. We talk about these three main palsies, and then we'll move forward. Now, before we talk about it, I'd like to again touch upon some basics, which will not only help you for this lecture, but any nerve injury lecture that you might face in your first year, in your second year, or in your fifth year. Okay. When I say injury, what does it mean by injury? It could be compression of the nerve. It could be Now, these are injury to any nerve. Okay, injury to any nerve. Basics of injury to any nerve. It could be compression. Something might be compressing on the nerve, like a herniated disc or a tumor or anything. It could be dissection, which is you cut the nerve completely, like in an accident or like a stab wound, right? It could be stretching of the nerve. A lot of the palsies that we're going to talk about are based on stretching of the nerve, right? So this is what I mean by injury to a nerve, okay? And just remember that injury can happen anywhere. But of course, there are some classical injuries that are more tested upon in your exam, okay? But you should know that injury can happen anywhere in real life. But focus on the classical ones that you were taught, okay? So when you injure a nerve, you can injure the motor innervation. When you injure the motor innervation, you lose the muscle contraction. You can lose the sensory innervation, you lose the sensations on the skin, or you can lose both, okay? And most of the time, it's both. If in a question stem, they only focus on just loss of sensation, then you think of all the sensory nerves that we've talked about, okay? But most of the time, it's going to be loss of muscle contraction, which is known as weakness, and is also going to be loss of sensation. Okay, so when you, so this might be some terminologies that you might face in your exam. Anesthesia, okay, the word aesthesia means feeling, okay? Sorry, aesthesia means feeling, and is without. So anesthesia is complete loss of sensation, okay? Paresthesia, again, let's break down the word. Aesthesia is feeling, para means abnormal, okay? So, or deviated from the normal. So paresthesias are abnormal sensations. These are basically the tingling sensation, the pins and needles that you might feel that if you're sitting for too long. Paralysis refers to loss of motor function. So that's loss of muscle movement, okay? And when you say palsy, that basically means paralysis, okay? So please remember these terminologies. Now, I believe that you guys have already discussed all these movements in your prior lectures. What do you notice about these movements except for circumduction? Forget about circumduction. What do you notice about the rest of these movements? Flexion, extension, abduction, adduction, medial rotation, lateral rotation. What is common to all of these?
They oppose each other.
Very good. They oppose each other and they occur in pairs. Okay. So if we have flexion, we have an opposing movement, which is extension. If we have pronation, we have supination. If we have medial rotation, we have lateral rotation. If we have abduction, we have adduction, right? So these movements are occurring in pairs, in opposing pairs, right? And now that is going to become important when we talk about the palsies, as I will discuss now by giving you the example, let's say medial rotation and lateral rotation, right? Let's say this person is at rest, okay? And we're talking about the medial and the lateral rotation of a person's arm. Okay, so around the shoulder joint, medial and lateral rotation, right? At rest, there's a balance between the medial and the lateral rotation. So the arm is in a neutral position. It's not medially rotated and it's not laterally rotated. Okay, this is at rest, right? Now let's say that I injure the nerve that is responsible for supplying the medial rotators of the arm. Okay, if I injure the nerve that supplies the medial rotators of the arm, what's the first thing that's going to happen? I'm not going to be able to medially rotate my arm, right? But in addition to that, what will happen to lateral rotation? It's going to be over pronounced, right? So if you think of it as like scales, right? So if I lose the medial rotation, the lateral rotation is going to be over pronounced. So at rest, my arm will be laterally rotated, okay? Exactly. If I injure the nerve that is responsible for supplying the lateral rotators of my arm, if I injure that nerve, first of all, I will not be able to laterally rotate my arm, right? So I will have weakness and paralysis of lateral rotation of the arm. In addition to that, the medial rotators are going to be overpronounced, okay? They're going to overpronounce their movements, and at rest, I will have my arm as medially rotated, okay? So just remember this concept, and you can apply this to any of the opposing movements that we've discussed. Abduction, adduction, flexion, extension, supination, pronation, any of them, okay? And this is very important so you can understand how the palsies have their clinical presentations. Why is there something called the waiter's tip hand? Why is there something called the claw hand, right? So this will help you remember and understand them better. So any questions till now? Okay. As I mentioned, when you injure a nerve, any part of the brachial plexus, you can injure the motor part or you can injure the sensory part. But we're going to focus more on the motor part because that's more visible to us. And they're going to focus on that in the exam as well. But as I said, the reason I focused a little bit on the sensory innervation of your upper limb is because they can act as extra clues that can confirm your answer, okay? So let's move forward. Okay, a nerve supplying a flexor at a joint is severed. What are the possible outcomes of this injury? Type in the chat. Okay, very good, Bayan. It's A and D, okay, and Mariam, and anyone who says it afterwards. Okay, A and D. Of course, the flexors will be injured, right? So I cannot flex my flex that joint, but the extension will also be overpronounced. If you remember the balances example or the scales example that I gave earlier. All right. So when we talk about the types of injuries to the brachial plexus, of course, as I said, injury can happen anywhere, but classically speaking, injury can happen either to the superior part of the brachial plexus, the inferior part of the brachial plexus, or injury to the specific nerves, okay? And my focus is going to be the first two, an injury to one specific nerve, which is the long thoracic nerve. But of course, I believe if you have discussed in your other lectures injuries to specific nerves like the radial nerve palsies, median nerve palsies, ulnar nerve palsies, you know, the hand of benediction, the claw hand, and all that stuff, please remember that as well. And remember, let me advise you this, like, remember the landmarks of these nerves. Know where these nerves are, okay? Don't just memorize the functions of the nerves, also know the anatomy, right? So know that when you talk about the humerus, right? When you talk about the humerus, let's say this is the humerus, there are three nerves that are related to the humerus, right? What is the nerve at the top? If I fracture the surgical, the axillary nerve, right? So if I damage the surgical neck of the humerus, I damage the axillary nerve. What about the mid shaft?
Radial.
Radial, very good. And what about this supracondylar, if I'm not mistaken? Yeah, supracondylar area.
Ulnar, I think.
Median nerve. Okay, median nerve. For you guys at this level, let's just stick to median nerve. Okay, so surgical neck humeral fractures will lead to axillary nerve injuries most of the time, not all the times. Radial nerve injuries can happen with humeral midshaft fractures, and median nerve injuries can happen with the supracondylar fractures of the humors, right? So this is a mnemonic arm, right? So remember the mnemonic arm, ARM. Okay. Not only that, I want you guys to know that, of course, if there's a midshaft fracture, right? Of course, in my mind, radial nerve is damaged. But if they're describing, let's say, damage like if they're describing loss of function of musculocutaneous nerve, then don't select radial nerve as the answer, right? Because if I'm not mistaken, although musculocutaneous nerve injuries by themselves are rare, they can happen in severe motor vehicle accidents, and they're also sometimes associated with the midshaft fractures, right? But of course, classically speaking, it's radial nerve. But of course, look at the rest of the question as well. Are they describing the motor weakness and the sensory loss that is relevant to the radial nerve or to another nerve? Don't just select radial nerve blindly, unless they ask, okay, midshaft is fracture, what is the most likely nerve injury? Of course, that is radial nerve. But if they've also described loss of muscle function, if they describe the person lost their supination, does the radial nerve supply any supinator? If I'm not mistaken, I don't think it does, right? And if they said that the loss of sensation is on the lateral forearm, is this the radial nerve? No, of course, midshaft fracture has taken place. The answer should be radial nerve, but the deficits that they've described go more with musculocutaneous nerve. So select that answer. Okay, so read the entire question is what I'm trying to say. Okay, moving on. So upper brachial plexus nerve injury is also known as Urooj palsy. When I say upper brachial plexus nerve injury, I'm mainly talking about injury to C5, C6 brachial plexus roots and or the superior trunk of the brachial plexus. Okay. Now, you have to remember the mechanism of these injuries, okay, because they might describe it in the question stem, and they might describe it in the question stem, and then you have to figure out the answer. So when Urooj palsy is taking place, supinator and extensor side of the forearm, I'm not sure, is it? A long time since I studied the rest of this anatomy. Supinator innervation, I think it is the radial nerve, yeah. Radial nerve, yeah. But that was just like an example, okay? Read the rest of the questions that I was trying to say. Okay, Urooj palsy. The basic mechanism of Urooj palsy is, I want you to remember, is increase in the angle between the lateral neck and the shoulder. Increase in angle between the lateral neck and the shoulder. And they can describe this as in any scenario. The classical scenarios that they describe it is in the horse riding injuries. Okay, the person falls down, increase in angle between the lateral neck and the superior shoulder. But they can describe it in a vaginal delivery. Okay, sometimes babies are big. Okay, and their shoulder might get stuck under the symphysis pubis, which is this one right here, and the obstetrician might have to pull the baby, might pull the baby in a way that stretches or increases the angle between the neck of the baby and the superior shoulder, and that can lead to Urooj palsy. Okay, so please remember the mechanism. Okay, because vaginal deliveries they might describe for Urooj palsies and Klumpke's palsy, right? But if you know the mechanism of how the injury actually happened, you can differentiate whether the answer is Urooj palsy or Klumpke's palsy. Okay, okay, I think I'm not sure if this is from your lecture or whatever, but these are the nerves and the muscles that are affected in Urooj palsy. Okay, I don't think that you have to know all of them, but you have to know the muscles that are affected. I don't think they're super important as well, but the main thing is what function is affected, what motor function is affected, right? But so if you go back to this, this is I think from your lecture slide, these are the motor function that are affected. This is the sensory function that is affected. Okay, so let's talk about the motor function that is affected first in Urooj palsy. C5, C6, right? So any nerve that is having its fibers from C5 and C6 is primarily going to be affected. And this includes mainly, classically speaking, these mainly 3 nerves. Okay, but as you see back here, includes a lot of the other nerves as well. and a lot of other muscles, but these are the main nerves and muscles that are affected. But in my opinion, the more important thing is to understand the movements that are affected, okay? And the classical presentation of Herb-Duchenne's palsy. So in Herb-Duchenne's
Did they
palsy,
ask about spinal levels? C5, C6, C7, T1. Can you go back to the...
here,
No, no. Back a little bit.
oh, this one, okay. Oh, this one, yeah. That's why I'm saying, I'm not sure. I don't believe they asked when I was student, but know it for the big nerves, know it for the axillary nerve, know it for the ulnar, radial, musculocutaneous, and the ulnar nerve, know it for the 5 main nerves and the long thoracic nerve. These are the main ones, okay?
Okay, thank you.
You're welcome. So these are the movements that are affected. Abduction is affected because of paralysis of the deltoid. Lateral rotation is affected because of some of the rotator cuffs. Flexion is affected at the arm, and supination is affected at the forearm. So these are the movements that are lost. The opposing movements are going to be overpronounced, right? If the opposing movements are overpronounced, then the patient is going to present with an adducted arm, which is medially rotated, which is extended, and which is pronated. Okay, so this is known as the waiter's dip hand. As you can see here, let's take the example of this baby right here. This baby's arm is adducted, it's medially, it's pronated, as you can see here, and it is extended. Okay, it's completely extended. So this is the waiter's dip hand. Please remember these 4 things, okay? And of course, there will be loss of sensation as well, right? So this is where the dermatomes kind of come into place, and dermatomes, which is C5 and C6, that is mainly affected, but I don't think this is super important. The main thing is the loss of motor function, which is the waiter's dip hand, okay? Of course, I'm just showing you pictures of babies because I couldn't find any adults, but they might present a question in which an adult is affected, right? Lower brachial plexus injury, also known as Klumpke's palsy, is mainly affecting your C5, C8T1 roots and or the inferior trunk. The basic injury, the basic mechanism of the injury is increase in angle between the arm and the thoracic cage. Increase in angle between the arm and the thoracic cage, and this can happen in any scenario. This can happen in a person who is hanging from the branch of a tree. This can happen in a person, in an obstetrician who is pulling the baby in the wrong way. So as you can see here, she's pulling on the arm of the baby. So there's an increase in angle between the lateral thorax and the arm, and that'll lead to Klumpke's palsy, right? So again, they might provide a scenario in which a baby is being delivered, and there will be some sort of palsy happening later on. Just don't select Klumpke's palsy or Erb's palsy just, blindly. Read the rest of the question. Read what the presentation is before you select the answer, because in both scenarios, the baby is being delivered. The mechanism of injury is what is going to, claim the answer for you. Now, there's also another mechanism of injury for Klumpke's palsy, and that is the presence of a cervical rib, which is a congenital anomaly in which an extra rib is present on top of the first rib, which is highlighted in purple here. This is the cervical rib, and this mainly compresses the inferior part of the brachial plexus, which is C8T1 roots. Okay, so please focus on the mechanism of injury. And these are the muscles and the nerves that are affected with their respective spinal levels. This is the thing that you have in your lecture slide. The main nerves that are affected are the ulnar and median nerves, okay, and the muscles of the hands that are affected. This is mainly how I remembered this, Klumpke's palsy. But again, more important than that is the presentation of the Klumpke's palsy, okay? So these are the movements that are affected. So I hope you guys know these joints, right? So the metacarpophalangeal joints are these joints right here, we see in my video. Then we have the proximal interphalangeal joints, which are these ones right here. And then we have the distal interphalangeal joints, which are at the very distal end of the digits, right? So flexion of the metacarpophalangeal joints and extension of the distal and the proximal interphalangeal joints are affected in Klumpke's palsy, right? So this is the metacarpophalangeal joints, PIP or proximal interphalangeal joints, and DIP or distal interphalangeal joints, right? So at these joints, the flexion is going to be impaired, right? So if the flexion at the metacarpophalangeal joints is paralyzed in Klumpke's palsy, how will the patient present? with extension at that joint, right? So if flexion is impaired, that this patient will have extension at the metacarpophalangeal joint. So these metacarpophalangeal joints will be extended. If you guys just do it, at your own ends, try to extend your metacarpophalangeal joints. So this is extension of the metacarpophalangeal joints, right? Now, extension at these joints, at the interphalangeal joints is affected. And so the patient is going to present in a flexed state because the flexion will be overpronounced, right? Remember the opposing movements? Because extension is impaired, the flexion will be overpronounced. So if I have extended the metacarpophalangeal joints and flexed interphalangeal joints, what does this look like? It looks like a claw, right? And this is why Klumpke's palsy presents with a claw hand. Okay, so this is the reason behind it. Don't just blindly remember, oh, Klumpke's palsy, claw hand. Sure, it's easy to in your exams and stuff, but know the reason why as well. And this is the reason why. All right. Any questions up until now? Okay, great. Okay, now if you go back to your lecture slide here, there's the mention of Horner syndrome. Are you guys familiar with Horner syndrome from Foundation or MSK? Horner syndrome. Okay, great. So what's the classical triad of Horner syndrome? Ptosis. What is ptosis? Ptosis is the eyelid that is drooping down. Next, that's correct. Ptosis, that is the correct spelling. Ptosis next. What's the rest of the triad? Anhidrosis and meiosis. Okay, so what do you know what these words means? Ptosis is the droopiness of the eyelid. Meiosis, it's constriction of the pupil, and anhidrosis is loss of sweating in that area. Okay, so that's ptosis, anhidrosis, and meiosis. And Klumpke's palsy may also present with Horner syndrome because of this reason. Let me explain it to you, but you do not need to know the explanation for your exam. Now, this is something that's super advanced that you will study in the second semester of your second year in your neuro block. But you guys are already familiar with the sympathetic nervous system, right? Now, the function of the sympathetic nervous system on your face, 3 of those functions are: number 1, it helps in elevation of your eyelid. Number 2, it helps in sweating on your face. And number 3, it helps with the dilatation of your pupil. Okay, so sympathetic nervous system on your face and your eye area, it helps with sweating, it helps with elevation of your eyelid, and it helps with dilatation of the pupil. So if I damage the sympathetic nervous system that is supplying my face, then I'm going to have the opposites of these 3 functions, right? I will have no sweating, that is known as anhidrosis. I will have no dilatation of my pupil. Instead, my pupil will be constricted, which is known as meiosis. And I will have no elevation of my eyelid, which is known as ptosis, right? So this is why Horner syndrome, this is the pathophysiology of Horner syndrome, or why Horner syndrome occurs. Now, why does it specifically has been mentioned in Klumpke's palsy is because the sympathetic nerve fibers that are responsible for supplying these 3 functions in your face are exiting in the T1 spinal nerve, okay? And as we know that lower brachial plexus injury or Klumpke's palsy involves T1 spinal nerve, right? The ventral ramus of spinal nerve, T1, is involved in Klumpke's palsy. So the sympathetic fibers in that T1 spinal nerves are going to be damaged. And so the sympathetic innervation of the face will be affected, and hence those 3 functions will be lost. And this is why patients present with anhidrosis, ptosis, and meiosis. Is that clear now? You do not have to know this whole thing. I just explained it to you guys, Yani, understand. All right. We'll move on to our last nerve injury, which is the long thoracic nerve injury before we move on to the questions. The long thoracic nerve is coming from C5, C6, C7. It supplies the serratus anterior, which is responsible for, number 1, keeping your scapula to your chest, keeping your scapula attached to your chest, to your thorax, and also adducting your arm above 90 degrees. Okay, so performing overhead functions like combing your hair or what else? I don't know, showering or something, right? So this is the function of the serratus anterior. Now, long thoracic nerve, what is the mechanism of injury? Is usually trauma. Okay, It could be stab wound to the chest. It could be mastectomy. Mastectomy is coming from mastos, which is breast, and ectomy, which means excision. So patients who have breast cancer who undergo excision or removal of their breast to remove the cancer, the surgeon might inadvertently injure the long thoracic nerve, and so they can get long thoracic nerve injury, right? So these are clues to your question. In your question stem, you might find someone who has a stab wound to the chest, the lateral chest. Because the nerve is super long, stab wound is easy to involve this nerve, right? Another clinical scenario might be a woman with breast cancer undergoes a surgery to remove her breasts, and now is presenting with signs of long thoracic nerve injury. Okay, so these are things that you should look out for in your question stem. Now, this is a serratus anterior, and the presentation is winging of the scapula. The classic presentation is the winging of the scapula, and of course, the patient will not be able to perform overhead maneuvers such as combing their hair or showering. Okay, so these are some of the other clues you might find in the question. Everything clear so far? Answer this question. Damage to superior trunk results in which classical presentation? Okay, very good. Urooj palsy. And now we're gonna solve some slightly more complicated questions. So of course, Yani, I guess up until now, the type of question that you guys have been getting in your exams and your TBLs are simple one-line questions, right? That test your recall memory. But from now on, you should start expecting bigger questions with bigger question stems, which involve a clinical scenario, okay? Of course, I'm not saying those questions are hard. I'm just saying they're bigger questions. So practice solving those questions. Practice reading the clinical scenario as quickly as you can, and practice figuring out the important positive findings in that clinical scenario, which will help you answer your question, okay? So this is my first question here. Is there someone who would like to read this question and answer it? If they can unmute themselves. Okay, so let me read the question. Okay, so the way you read this question is, in my opinion, you should read the whole question, okay? Some people say that start reading the choices and then go back to the question. I think you should read the whole question and try. So the way that you read it as quickly as possible is that you practice solving this question, right? So this is a woman who is admitted to the hospital with an injury to the superior trunk of the brachial plexus. They already gave you the diagnosis, which is Urooj palsy. Which of the following conditions is expected to be present during physical examination? A, B, C, or D, or E, and most of you are saying B. So let's see now, okay? Now, wing scapula. That is injury to what nerve?
Long thoracic.
Long thoracic.
Very good. So A is not the correct answer, right? What about B? Inability to laterally rotate the arm.
That's infraspinatus, basically. So
Okay. Is that the correct answer?
I think so, yes.
Yes, that is the correct answer. Okay. So those patients cannot laterally rotate the arm. Even if you don't know the muscle, even if you don't know the nerve, just remember the Urooj palsy present with medially rotated arm, right? So if the medial rotation is overpronounced, this means the lateral rotation must be lost. And so B is the correct answer. What about C? Paralysis of the muscles of the hand. That comes more with Klumpke's palsy. Paresthesis in the medial aspect of the arm. What nerve is responsible for this?
Medial. No.
Yeah,
Sure.
go ahead.
Medial cutaneous.
Very good. Medial cutaneous nerve of the arm. Okay, simple. They've named it very simply, medial cutaneous nerve of the arm. And E, loss of sensation of the dorsum of the hand. So that's radial nerve, ulnar nerve, and even a part of the median nerve. So the correct answer is B. Okay, let's move on. This is a slightly longer question. I'll give you guys, let's say, a minute to solve it. Put the answer in the chat unless someone wants to unmute and answer. All right, so we have a lot of C's here. Let's read the question. Several weeks after surgical dissection of her left axilla for the removal of lymph nodes for staging and treatment of the breast cancer, a 32-year-old woman was told by her GP that she had winging of the scapula. Oh, swinging of the scapula, this means long thoracic nerve injury, right? But let's read the rest of the question to figure out some other clues to confirm her answer. She told the physician she also experienced difficulty raising her left arm above her head, so she is having trouble performing the overhead maneuvers. Again, further confirming that her answer is long thoracic nerve injury. At this point, you can go ahead and you can select your correct answer. Okay, so what was the origin of this nerve? What is the origin of the long thoracic nerve? C5, C6, C7, brachial plexus roots. And so we look for that answer, and that correct answer is C, as you guys have correctly mentioned. Okay, so this question I also wanted to illustrate the fact that you will have a lot of distractions in your question stem, right? So look at all of this. All of this did not have to be there. They're just putting it as to waste your time, to distract you, but they're also giving you clear-cut answers right here. Winging of the scapula, overhead maneuvers, difficulty, right? That help you cling your answer, but the rest of them are distractors, and you should be able to not be distracted by the distractors. Okay, in a subsequent consult visit, none of this is important really. Okay, so the only way that you learn to pick out the important positive findings, pick out the important clues to confirming your answer, is by practicing as many questions as you can. All right, the correct answer was C. Next up, we have this question. I think this is easy, or you talked about it. Which of the following are directly responsible for the formation of the brachial plexus? Okay, lots of D's here. Yeah, that is correct. Ventral rami of the C5 to T1 spinal nerve. I hope I cleared out that concept. Okay. Dorsal rami never form any plexuses, and ventral root is basically the ventral root of the spinal nerves, which is not directly involved in the formation of the brachial plexus. Next up, a clinical study is being conducted to look into the feasibility of using the pectoralis minor muscle as a flap for thumb reconstruction in patients who have lost their thenar muscles. While retrieving the muscle in one of the study subjects, the surgeon noticed a section of a blood vessel that is running immediately deep to it. What parts of the brachial plexus are associated with this blood vessel? The correct answer is E. Very good. Okay, so look at the whole question stem. Use this information, right? You don't need this to solve your answer. The only thing you need to know is that we're talking about the pectoralis minor muscle. We're talking about, and they're asking what parts of the brachial plexus are associated with this blood vessel, right? The only part of the brachial plexus, the only main part of the brachial plexus that is associated with a blood vessel is what? It's the cords, right? So the second part of the axillary artery, lateral medial posterior cords, right? And so the answer is cords. Now, to further dig deep a little bit into answering why is this the correct answer, as I said, the pectoralis minor muscle is what divides the axillary artery into three parts. If you remember, this was the pectoralis minor muscle, and this was the axillary artery, right? It divides it into the first, the second, and the third part. Okay, now they're asking, while retrieving the muscle in one of the study subjects, the surgeon noticed a blood vessel that is running immediately under the pectoralis minor, okay, or immediately deep to it. You should understand the word deep. It's an anatomical term, right? So if something is deep, it's immediately under the pectoralis minor. And if I remove the pectoralis minor and there's a part of the blood vessel that is running immediately under it, that is the second part of the axillary artery. And we know that the second part of the axillary artery is associated with the cords of the brachial plexus. So the correct answer is E. So I hope you know why. Siham, okay? Clear? Okay, go. Okay, next question. An 8-year-old male is being evaluated for an upper limb deformity. Complete history was taken from the patient's parents, which was subsequently followed by a thorough physical exam. The astute pediatrician identifies the deformity and orders the chest radiograph, which is shown here, and shown the abnormality is labeled with the red arrow here, okay, which confirms the suspicions of a cervical rib. What is the most likely clinical presentation of the child? Are you sure it's A? Any more answers other than A? Okay, we have a C. Okay, so I have an excellent question. How do we approach this question? Okay, let's start from the beginning. But now, this is a baby. This is a pediatric kid. This is a kid, right? He's being evaluated for a deformity of his upper limb. Okay, a deformity of his upper limb. But now, all this other information is, by the way, is useless. That the complete history was taken, physical examination was done. You don't need to know all that. What you do need to know is that a chest X-ray was ordered for this patient, and it showed a deformity. You do not need to know how to read chest X-rays, by the way, okay? Because they've already told you that this confirms your suspicion that this patient has a cervical rib, right? So what connection can you make with cervical rib and upper limb deformity?
Clumsy.
Can you repeat that, please?
The Klumpke syndrome.
Very good. The Klumpke's palsy, right? The Klumpke's palsy. So the cervical rib compresses the lower brachial plexus, which is the Klumpke's palsy. And what is the presentation of the Klumpke's palsy?
The claw hand.
Claw hand. Okay, very good. The correct answer is claw hand. So either could be right or left, right? So you just look at the image, look at it logically, right? The abnormality is on the left side or the right side?
It even says L and R on the, what do you say?
Exactly.
This
It says
radiogram.
L and R. They've even told you that this is the left side, this is the right side. So the abnormality is on the left side. So the left side will be affected. And so the correct answer is A, which is the left claw hand. Okay. And if you don't, if that's still is something advanced for you guys, always remember, wherever the heart points in the chest X-ray, that's the left side. That's it. Most of the time. Some people, what they have is they have the heart is pointing the opposite side, but that's rare. So most of the time, whenever you see a chest X-ray and wherever the heart is pointing, that's the left side of the X-ray. Okay. Probably don't need this for now because left and right is already mentioned here. Is this clear? Was this question clear? How do we know it's Klumpke's palsy? Because we just rely on the information that's given that it's cervical rib, which is mostly associated with lower brachial plexus injury, which is Klumpke's palsy. Okay. All right, I shall move on. Right claw hand is not correct. Scapular winging is with long thoracic nerve injury. D and E are Erb's palsy, which are upper brachial plexus, which are less likely to be affected by a cervical rib. And so they're not the correct answers. Okay, next question. A 29-year-old man is rushed to the ER after falling down while horseback riding at the local equestrian club. He has mild to moderate pain in his left shoulder and a small laceration on his right knee. Analgesics were administered and the knee was cleaned and dressed. The man was discharged home on pain medications. A week later, he visits the ER again, complaining of being unable to flex his left forearm. Physical examination revealed that the left arm was adducted, internally rotated, and his left forearm was in fixed pronation, which of the following is the most likely injury during his fall a week ago. Lots of C's here. And yes, the correct answer is C. Okay, so let's approach this question again. Lots of useless information, lots of distractions here, but the main thing that you need to focus on is that this patient, he fell down from horseback, and then his presentation is he's not able to flex, and when they examined his arm, the arm is adducted, internally rotated or medially rotated, and pronated. So unable to flex or over pronounced extension plus adduction plus medial rotation plus pronation. What is that? The presentation of Erb's palsy, right? And Erb's palsy is when you damage your upper brachial plexus. So that's C5 to C6 brachial plexus roots. C5 to C6 brachial plexus roots are the same thing as C5 to C6 ventral rami of the C5, C6 spinal nerves, right? And so the correct answer is C. Okay. Now, musculocutaneous nerve is not the correct answer. Of course, musculocutaneous nerve would be affected in Erb's palsy, but there are other nerves that are affected, and there is a more correct answer here, which is C. C5 to C6 spinal nerve roots do not form the brachial plexus directly, okay? So that is not the correct answer. C5 to C6 ventral rami form the C5 to C6 roots of the brachial plexus, which are the upper brachial plexus roots, which would be affected in upper brachial plexus injury, which is Erb's palsy, which is exactly described in this question. And so that is the correct answer. C8, C7, C8, that is not correct. Inferior trunk of the brachial plexus is Klumpke's palsy, and that is not the correct answer here as well, because that presents more with a claw hand. Is this clear? Any question? And if you had any misconception, was that cleared out in this question
I have
here?
a question.
Yes, please.
Yeah, so basically here what's affected, it's like the biceps, right? Because like could it be the biceps? Because they're saying that the arm was adducted and it's pronated, so we cannot supinate it and we cannot abduct it.
Flex it. Flex it.
Yeah, flex it. So
Exactly. So
doesn't the
you're absolutely
muscularis nerve supply the biceps?
okay. Now let me ask you this question. What about the adduction? He had overpronounced adduction. Does musculocutaneous nerve supply any abductor muscle, which would lead to loss of abduction and overpronounced adduction?
Oh, no. Yeah,
all right. So the musculocutaneous, yeah, okay. So be sure to read the whole question. Make sure that the answer that you're selecting does not exclude the other important clinical clues. Okay, is that clear?
Yeah, okay, clear.
Okay. Lower part of the brachial plexus is more towards cervical rib. Yes, that is correct. Okay. Any other questions so far? So let me give you any kind of a trick to know this, right? If they're giving you lots of motor function and lots of sensory function that are limited to one nerve, then the answer is obviously going to be one nerve, okay? But if they're giving you lots of motor loss, sensory loss here, abduction is lost, and then flexion is lost. These are functions that are carried out by two different nerves. So the answer cannot be one nerve. It has to be something upper, something more proximal, which are roots of the brachial plexus, okay? I hope that makes it clear. I'm going to move ahead. I think this is it. Okay. Mnemonics, I think you guys already know these mnemonics. So these are the different branches of the brachial plexus, and these are the mnemonics that you can use to remember them. I think you guys should be already, you guys, probably someone already told you about them. LML for lateral cord, posterior cord is ulnar, okay? Now, for me personally, when I remember ulnar, I get confused with posterior cord because the posterior cord does not give off the ulnar nerve. So I replace this mnemonic with a mnemonic called CINAR, okay, which is more relevant to the posterior cord. And the medial cord is M4U, okay? And the reason it's M4U is there are 4 M's, 1, 2, 3, 4, and 1 U, which is the ulnar nerve. Okay, so this is the end of the review lecture. I hope you guys enjoyed. If there are any questions, please feel free to ask. Before we finish, I would like to tell you guys and advise you guys that you should solve as many questions as you can before your exam. And the resources that I highly suggest actually, is number 1, Gray's Anatomy review book. Okay, so go to the upper limb section in this book and solve the questions, MCQs, and they're all clinical questions, big questions. Okay, so they will provide you with excellent practice for your exam. And let me actually tell you a little story here. I solved all the upper limb questions from Gray's Anatomy review before my exam back in 5 years ago. And one of the questions was actually directly repeated from here. Okay, so sometimes they might repeat the question directly from this book. So this book is, I really love this book. I use it for all of the MSK. AMBUS, I'm not sure if you guys are familiar with AMBUS, although I feel like maybe AMBUS questions might be slightly harder, but if you can solve them, if you have access to AMBUS, please solve the questions from AMBUS as well, and you can easily filter out the question that you want. Lastly, the University of Michigan Medical School website. I don't know if you guys already know this, but this is also a really nice website that not only you will find anatomy diagrams, cadaveric pictures, very nice models, but you will find very important questions here as well, which at least in my time, they love to repeat questions from this website. I don't know if they still do it, but if you want to practice clinical questions, these two websites, Gray's Anatomy Review is I highly suggest it, and AMBUS is super good as well. Okay, I hope you guys have a wonderful exam. My main resources for the entire lecture was Gray's Anatomy for students. And these are things. Forget this. I mean, remember it, but forget it for now. And that's it. I hope you guys enjoyed. I hope you have your misconceptions cleared out. I hope you guys remember the stuff that we learned, and I hope this was a good review before your exam. And I hope that I gave you good advice for your exam. And I hope you guys do excellent in your exam. I will share. Okay, before I finish, I have to remember 2 things. I will send. 2 things. Number 1 is the presentation. Okay. And I will not send it in a PDF. I will send it in a PowerPoint format so you guys can look at the animations and stuff. And number 2, let me just show you this to you guys. Can you guys see my screen?
No, we can't. You have to reshare, I think.
Oh, 1 second, please. Okay, can you guys see the Word file?
Yes.
Okay, so this is a bunch of questions that I made related to the brachial plexus. Most of them are clinical questions. There are also SAQs towards the end. So I will send Amina this file as well, so you guys can practice these questions at your own time. Thank you so much for attending, for taking out the time, and take care. Assalamu alaikum. Thank you, Amina, for moderating this session.
Of course. Thank you for explaining it. I think there was a question in the chat that wasn't answered. Fatima said, I can't get the spinal segments of axillary nerve. Why not from C5 to T1?
Okay, so let me explain that. Whoever wants to leave can leave, but I will just explain this to Fatima. Okay. Okay, so if you now, as I said, for the root values of these nerves, right? If you remember, if you go back to the first slide that I told you, right? A nerve is a bunch of nerve fibers, and these nerve fibers can be coming from anywhere. So if you look at the musculocutaneous nerve, it comes from C5, C6, C7, and those are as actual root values. But for the axillary nerve, C5 to T1 are not as actual root values, because the way that it actually happens is this. So only C5 and C6 will contribute their nerve fibers to the axillary nerve. So imagine it's happening like this. So C5, C6 have their fibers, and they're coming to the superior trunk. Then they're going to the posterior division, and go to the posterior cord, and they go to the axillary nerve. The fibers come from C7, C8, and T1. They just don't go into the axillary nerve. That's the explanation. Okay? Fatima? Right? It's just how things are. I mean, this is how anatomy is. There's no logical explanation to this, but it's just that the fibers are not entering axillary nerve. I can't do anything about it. It's just the way it is. Okay, you're welcome. All right, I think this is it. Take care, everyone. Assalamu alaikum.